Hey everybody, welcome back to the ECG channel. My name is Reid, and don't forget that if you want to follow along and make your own notes, you can download this PDF of this document down in the description below, and you can save it, share it with your friends, do all the things you want to do. And don't forget to like this video and subscribe to the channel if you want to see more. So let's jump into it. This is a fun ECG, and the reason why I put this one on day 129 is because it's going to be similar, but a small difference between this and 128. And so you get to kind of contrast and compare some of the physiology here. It's pretty neat. So let's go ahead and get started. So the first thing we're going to do is we're going to look at the forest, right? So we're getting an idea of what we think is happening. And so maybe I'll choose like lead 2 rhythm shape. You see I've got a regular rhythm. Seems to be kind of tacking along. And if you look, you see you've got a nice regular rhythm here. Some of you are probably thinking like, well, like why is this like up and down? You know, who knows, right? Maybe he or she were kind of breathing heavy, you know, who knows, right? But regardless, that's our, we got a regular rhythm. If we look at the rate here, we see we got a QRS that starts on a solid line here, so we count 300, 150, 100, 75. This is 60, so somewhere between 60 and 75. I'll call it 70 beats per minute. So we've got a nice kind of regular rhythm at 70 beats per minute. It's reassuring. If you look at the width of the QRS, though, it looks sharp, but it's kind of on the upper limit of normal, right? You see the QRS starts right here, and it ends there. So I would even call this just above the upper limit of normal, right? So our QRS is like just over 120 milliseconds, maybe like 130 milliseconds, so just a little bit wide. You can see here in V1, it's actually a little bit wider and easier to tell that it's wide, right? Sometimes you just have to scan through and see which leads kind of give me the best QRS morphology. V3, you've got a nice wide complex QRS, right? So we've got a wide complex rhythm at 70 beats per minute. And I notice that I see P waves in front of my QRS. So here are my P waves. So this makes me think that I might be having a rhythm coming from the atria, conducted through the AV node aberrantly as it goes throughout the ventricles, maybe like a bundle branch block, right? Just starting to formulate a little bit of an idea here. So let's evaluate those P waves. We said we have P waves, and we do. We have P waves that are upright in lead 1. They're upright in AVF. Tells me that they're going down and to the left, which is what you typically see when things come from the SA node, right? So this looks like a sinus P wave, so that's good. Next thing that's going to happen is the AV node is going to capture that signal and delay it. And so let's figure out for how long is it delaying it, and is it delaying it appropriately every time? Is it the same? And so, what I can do is I can find a QRS that I want to measure the PR interval, and I scan through, and maybe here, maybe this is a good one, right? You get QRS that starts right on the solid line, and you've got a P wave that is just at that solid line. So that PR interval is just on the upper limit of normal. So our PR interval here is 200 milliseconds, and we know that 200 milliseconds is the upper limit of normal. So we are 1 millisecond away from this being a first-degree AV block, but it's not. But we also need to make sure that every P wave has a QRS, and so you kind of scan through and you make sure every P wave is associated to a QRS, and you look in between to make sure that there are no extra P waves, right? Our T waves are nice and smooth. Our P waves are usually really sharp, and so you can kind of look for those. V1's a decent lead to look for, but I would implore you to look through most of the other leads, right? Scan through lead 2, right? Scan through V5, scan through all these leads, right? Get that kind of in your mind to look for. So, okay, we've got PR interval that's within normal limits. Let's take a look at that QRS complex. So we said it was a wide complex QRS, right? And we measured it out, and it was maybe 130 milliseconds, maybe 140, who knows. We've got a QRS axis that is isoelectric in lead 1. So lead 1 is here on this horizontal plane. And if it's isoelectric to lead 1, that means it's perpendicular. So we have a QRS axis that's perpendicular to lead 1. So we're like, well, which way? Is it perpendicular up or perpendicular down? But we see we have an upright, so it's going towards AVF, so it's going down. So that is right at positive 90 degrees. So we're just right at the right axis. So a little bit of a rightward axis here. We're not going to call it right axis deviation. And so thinking, well, I wonder if we have like a right bundle branch block. It's a wide complex QRS that could shift the axis to the right, right? And we said we had a wide complex QRS, so we need to evaluate for that anyways. And if you look at V1, we see we have an RSR prime, RSR prime, right? And that morphology in the leads V1 and V2 tell us that we might have a right bundle branch block. Because those R prime forces, remember, are forces that are going towards the leads that are capturing the right ventricle. And if you look in the lateral leads, like V6 over here, you've got this slurred S wave. It's subtle, but it's there. It's even more so there in the high lateral leads. In this case, lead AVL, look at that slurred S wave. Look at lead 1, slurred S wave. So we've got slurred S waves in the lateral leads. Well, why? Well, if the right bundle is blocked, say we've got, there's our right bundle branch block. We've got fast, rapid conduction through the left bundle, all through the area supplied by the left bundle, and then cell to cell, late, because it takes a long time to go from gap junction to gap junction through to the right ventricle that's supplied by the right bundle that was blocked. And so we get negative S waves in AVL in lead 1, right? And so you get like a normal QRS to start with, and then you have this negative slurred S wave, and that's what we're seeing. And so we get a right bundle branch block. It explains our wide complex QRS in the setting of a normal sinus type of rhythm. Let's look at our QT interval, right? Our QT interval, we can kind of take maybe a couple R to R intervals, kind of measure midway between them, and my T wave seems to end by that point, so I think I've got a decent QT interval. It's not too long. Remember the QT, the reason why I like to do the R to R intervals is because we know that the QT is repolarization, and repolarization is rate related. So you can actually use the rate, which is kind of like an R to R, to eyeball it. And obviously you can calculate it. Last thing we're going to do is we're going to look for pathological Q waves, which tell us if we have a history of prior myocardial infarction. And any SE or T waves that are elevated or depressed that are scary to us, I don't see any, right? You're always going to have this inverted T wave in the leads that are really capturing that right bundle branch block, right? So that's like the kind of ST strain almost in a way, right? You have a depolarization abnormality, you're likely going to have a repolarization abnormality. And so now we can put this all together, and what do we have? We have a sinus rhythm with a right bundle branch block. Now, what do we want to do with this patient going forward? Probably, maybe you'll see where's that PR interval at in 6 months, right? Next time you see him, you might think about it, right? If they're having new symptoms, well, I don't know. Did they develop a different PR interval change, which would indicate what? AV nodal disease? I don't know. It's all clinical scenario based, but I want you to think, why does this person have conduction disease of the right bundle, right? Something happened to their right bundle. Do they have lung disease? What is it? Do they have a heart attack that impacted the septum? And, is their AV node going to maintain their health as well? So just little things to think through. I hope this helps. If you have any questions, throw them down into the comments. And if not, think about subscribing to the channel if you enjoy these videos. I enjoy making them, and I hope you enjoy watching. So thanks so much for coming to the channel, and I hope you have a great rest of your day. We'll see you at the next ECG video. Take care.